चाहिए. अब सारे थ्रोट इन्फेक्शन को मिलता रहेगा तो सारों को मिल जाएगा. Okay, now coming to the fourth case. Now this is a child, 5-year-old, cough, cold, low-grade fever, earache, non-sick, fever is 101, no other associated morbidity, right tympanic membrane is congested, and the left tympanic membrane is normal. What is the ideal treatment to use this? Bataiye. Okay. Now we have published these guidelines, which was after a Delphi study, and in this study we found that if the child is more than 2 years, and this is a consensus statement of all these experts from all over India, and many of these are leading ID experts and leading microbiologists of India and with ENT persons. And answer is, after reviewing the literature, if the children are more than 2 years and there's a non-severe otitis media, most of them, they settle down with analgesics. You may use ibuprofen or you may use paracetamol. 80 to 90% will settle down in 2 days. If they don't settle down in that situation, you may use amoxicillin. Okay, and that's the answer for that. Going to the next case, this is a 4-year-old child with dysuria. History of UTI 1 month ago also. Ultrasound is normal. Now similar presentation, the child has come. Fever is up to 101. Lot of dysuria means there are a lot of symptoms while passing urine. There's a history of constipation which explains repeated UTI. Urine routine is full of WBC. The child is started on cefaxime. And the child is much better after 48 hours. But the report comes this. Means it's resistant to cefaxime, ceftriaxone, ciprofloxacin. So what should I do? It's sensitive to cefoxitin, chlorphenicol, amikacin, nitrofurantoin, piperacillin, tazobactam, meropenem. क्या करें जी बताओ? Continue with cefaxime, absolutely correct. See, what happens is, if there is this type of a scenario, then if MIC is more than 2, it's very good proxy for ESBL production by the bug. And if it is sensitive to cefoxitin, it means then the MC is not being produced. Now see this chart. See, in ampicillin, and if you give this standard dose in adults, the peak concentration is 3 to 6 microgram per ml. But see the urine concentration, 1000 to 2500 microgram per ml. It means you are having a huge concentration in the urine. All beta lactams are increased markedly more than 100 times in the urine. That's why there's a difference between vivo and vitro sensitivity. So in this case, you can use this PKPD and you must give a message to the parents. Patient is improving on this, great. We'll give this treatment of cystitis for 5 to 7 days. And if the child gets a relapse, maybe I have to go to alternative drugs. Next. This case is 5-year-old, fever is 7 days. Day 1 and 2, the fever was 100, 101. Day 4 to 5, fever increased to 103, 104 with shivering. Fever is intermittent with paracetamol and many times given mefenic acid. Decreased activity, decreased appetite, mild abdominal fullness after 2 days. And the CBC is like this, typhoid and Vidal negative. So clear cut, this is a patient of enteric fever because there is a step ladder pattern. Shivering occurred not at the onset, but when the instance fever has gone up to 4 days, because what happens in other infections like malaria, tonsillitis, pneumonia, the shivering comes in first 2 days. If the shivering comes after 3-4 days, it means the bacteremia is building up, and that happens in cases of enteric fever. So very classical of that. Intermittent pattern, because most of the fevers have become rhythmic because of massive use of paracetamol and other strong antipyretics. And fever of more than 2 days, if there's a non-localization, in India, the epidemiology suggests me most cases are because of enteric fever. And instead of typhoid and Vidal, which are very unreliable tests, and Vidal will become positive after 7 to 10 days and still unreliable. If you go by culture, this is the most gold standard. If you see CBC is very suggestive. In CBC, counts are usually normal or low. The polymorphs are little more than lymphocytes. There's eosinopenia is there. CRP is invariably increased, and urine routine is normal. So this combination, which it suggests there's no other anything else, indicates with this clinical picture that most possibly I am dealing with enteric fever. This child was treated with ofloxacin amikacin. What is the message here? इन डॉक्टर साहब ने पिछले 15 साल में CME अटेंड नहीं करा, ठीक है, ओके, अच्छा, we stopped ofloxacin amikacin, sent blood culture, Cefaxime was started 20 milligram per kg in 2 divided doses, and beta-lactam antibiotics, remember, should always give 12 hourly because they work on the principle of time about the MIC. The report came as salmonella even if the patient had received antibiotics. And so no resistance to Cefaxime and ceftriaxone we have seen ever. I think one case in 2017, if Dr. Pisha is there, this was her patient who had resistance. Otherwise, we had not seen a single patient after that, after 8 years, single patient resistant to Cefaxime, ceftriaxone. So delayed effervescence, yes, is usually seen. There's no response to treatment agar hai, so think of complications. Okay, and what about combination of Cefaxime and ceftriaxone with azithromycin, or either of the two, Cefaxime or ceftriaxone with azithromycin? This is a Nepal study which talks about combination, and this is a study done in 2018 where both the drugs were used. And what is the summary? There's no firm evidence to support the use of two drugs, and the evidence says the effervescence is 7 hours earlier if combination is given. So I think it's better to preserve azithromycin in case we have a Pakistan-like situation where the resistance came in Karachi and Sindh area, and this typhoid was resistant to most of the bugs. Now 2 cases, very short cases. 17-year-old male underwent emergency splenectomy in our center about a few months ago, received PCV 13, followed by PS 23, Hib, meningococcal, TCV, all capsulated bugs that were covered on penicillin prophylaxis, has come with fever of 102 and no focus. The patient is not sick. और उसकी प्रॉब्लम यह है कि उसे बेंगलोर जाना है for unavoidable reason, some exam or something which cannot be avoided. So what should I do? My choices are these. What should I do? The patient has come with fever of 102, there's no focus, the patient is not sick. Now, should I give paracetamol and tell them go ahead with your travel plan, or वहाँ जाके pediatrician को दिखा लेना? I tell them start oral antibiotics, ciprodoxime or amoxiclav, and then travel. Should I tell them admit and cancel your travel plan? And fourth is send investigations and start ceftriaxone. A. B. CB. Chalo, okay. See, in this patient, the problem is this is a immunocompromised child. You may have a situation that you send the patient and next morning the patient comes to you in shock. So it's very necessary in these patients, and I tell them admit, cancel your travel plan because this is an immunocompromised child. They say, Dr. Penicillin to mil raha hai because the most common bug is pneumococcus, and pneumococcus may be resistant to penicillin also. So I tell them what you do is, you take injection ceftriaxone, I take blood culture, give injection ceftriaxone and tell them you have a 2 or 3 hours flight, go there and reach in Bangalore and immediately contact one of my friend in Bangalore and for the follow-up. And luckily this report came as more in favor of culture negative, and the patient was okay, no further fever, and there were viral-like symptoms on next day, cold, cough and all that, and we stopped the treatment. Now, in this case, I think the host was the most important factor. Immunocompromise. This has happened in our hospital a few years ago when the patient came in the night. The child had splenectomy done. The doctor, emergency doctor, never noticed this. There was fever. He said कि कल सुबह OPD में दिखाना. And at 4 a.m. the same doctor had to attend this patient in shock. Okay. Now this is 10-year-old male child, last case, high-grade fever for 12 hours, vomiting, restlessness, few petechial spots on face. There was an outbreak of meningococcemia in the city. Call from a doctor 30 kilometers from our hospital, and your advice to the doctor. अब इसको क्या करना है, बताना है आपने कि इस तरह से कॉल आती है, तो these are the choices. Send the patient fast to me in the hospital. Okay? Send him to the nearest lab for blood culture and give IV ceftriaxone. And third is give ceftriaxone and then refer. So in this patient, I think most of Delhiites are very familiar with this. Again, this bug is very virulent. It may not give you few hours. So what we seen in our meningococcemias in 2005 and 1985, but the patient used to be coming in the OPD in the morning, and you don't diagnose, by evening they were dying. So this patient is fulminant sepsis, they can go into fulminant sepsis. So there was a meningococcal, just I'm finishing in 2 minutes, meningococcal disease, there was an outbreak in Delhi, and this we faced a lot. And what is the likely bug? The virulence. Virulence is really worrying. So if there's a life-threatening infection, the patient is immunocompromised, the high probability that waiting will be dangerous. So there and then, in the last patient, what happens is, अगर उसको आप कहते हो कि आप चलो आप चले जाओ hospital, he may take 2-3 hours, he may take second opinion, and this will be very, very costly affair. And waiting dangerous in some situations, don't lose time, send investigations and start treatment. And in these cases, presumptive empiric use of antibiotics is justified. Now, antimicrobial stewardship has an effort to give rational antibiotic therapy. Then these are other things like major antibiotic prescribing, which leads to good clinical outcome, microbiological outcome. A lot of antimicrobial consumption is reduced. It saves the cost. And then the third aspect is you must have infection controlled in place.